Trauma Life Support by Dr. Stephen Masharia, General and Trauma Surgeon. Trauma is a leading cause of death in the first 4 decades of life, with significant socioeconomic impacts, like that is huge costs in healthcare, affects the most productive sector of society, and leaves many people with disability. And we can understand this by looking at statistics, which show that about 10 minutes, 2 people are killed, 350 disabled, and $7.8 million spent on trauma, which works out annually to 60 million people injured, 30 million requiring medical care, 3.6 million are hospitalized, and 9 million injuries visually disabling, and about 300,000 of those injuries are permanent. And this is not looking at the impact on the socioeconomic productivity of the society for those people who are so injured. With this in mind, we can then understand the importance of dealing with trauma care seriously from a socioeconomic point of view. And the ATLS course was started in the United States by an orthopedic surgeon who was dissatisfied with the trauma care he received after an accident. And he argued that the previous management of trauma patients following the traditional clinical model was unsatisfactory, and that a new focus was a new approach was required, which would prioritize on life-saving measures and not necessarily a definitive diagnosis. And the goals of the ATLS course are: 1, to assess the trauma patient's condition rapidly and accurately, resuscitate and stabilize patients according to their priority, to determine if a patient's needs exceed a facility's capability or capacity, and arrange appropriate transfer, and ensure that within this transfer the patient is cared for adequately, optimally. Where a history is necessary before physical examination is done to make a diagnosis, whereas it's been found in trauma that history taking and physical examination can go hand in hand, and in fact a quick assessment of the injuries is more important than a detailed history taking. And the 3 concepts that necessitated this paradigm shift are: 1, it's important to treat the greatest threats to life first, some of which may not be obvious. And secondly, the lack of a diagnosis does not impede treatment that is obviously indicated. And thirdly, a detailed history is not essential before beginning the assessment and management and resuscitation of a trauma patient. And this shift in thinking necessitated by a study of trauma deaths, the pattern of deaths after trauma, which is represented in this graph here, showing the trimodial death pattern. And what this basically means is that from the time of injury, there are 3 peaks of death, and which can be separated in time. The first peak is the one that claims about 50% of the patients and occurs within seconds to minutes after trauma. And in this peak, there are the causes of injury are usually quite severe, sometimes not compatible with life. Then there is a second peak claiming about 30% of the people, and in this peak The causes of death are conditions like shock and hemorrhage, which can be dealt with if a patient gets to competent trauma center early or encounters a competent trauma team. And then there is the third peak, which occurs in weeks to months, and in this third peak the causes of death are shock and sepsis that resulted from inadequate or severe trauma. This has led to the concept or the realization that trauma care, there is what's called a golden hour of trauma, where care within this period will have a big impact on life, will save many lives. And this is not really just 1 hour, but it's the first few hours after trauma. And in order for this hour to have the greatest impact, there has to be rapid and focused intervention to save lives. And the effect is that it reduces deaths within the second and third peak. The first peak is usually difficult to do anything about, except maybe preventing the trauma in the first place. The golden hour of trauma requires a team approach and a good emergency medical services system. And this is important to institute community-wide. The ATLS approach follows the mnemonic A, B, C, D, etc. And each of these letters mean something, and they define the priorities in care. So that A stands for airway, and when we deal with the airway, we have to control the cervical spine, which might be injured. B stands for breathing and ventilation. C stands for circulation. D for disability and neurological status of the patient. And E means that we need to expose the trauma patient in order to assess all their injuries quickly. And as we expose the patient, we must take care not to expose them to hypothermia. After a quick assessment in the primary survey, the most life-threatening injuries are managed in resuscitation urgently, and usually primary survey and resuscitation proceed hand in hand simultaneously, and they require many team members who work as a coordinated unit and who have to therefore train together and be ready for this kind of care. And training and preparation are essential. After the resuscitation, they then go to a more thorough examination of a patient, head-to-toe examination of a patient, and in this time we also take a complete and focused history. Not a long rambling history, but a concise history that is defined by the information, or determined by the information that you require for further management. After the secondary survey, we then formulate a management plan and consult the necessary specialists. The history we take in the secondary survey can be summed up by the mnemonic AMPON, and the history we are interested in is the history of any drug allergies, any medication the patient might be under, what his past history of illness is, the time when the patient took the last meal, and last, and usually the most important, is the events, what happened. And this history helps us to determine the mechanism of injury. And the team approach is important both in the pre-hospital and in-hospital setting, and it requires certain preparations to be put in place, and this is actually part of the emergency medical services system, EMS. We need transport guidelines and protocols, mobilization of resources, and arrangements with medical facilities for transfer. And in the hospital phase, we need planning and training and availing of the requisite equipment and personnel. Training is essential to the team members because they need to understand each other and they need to develop the necessary skills, and these are preceded certainly and obviously by the knowledge, which changes their attitude and helps them to practice the skills. And part of the training and preparation is improving resuscitation facilities, and this requires investment in infrastructure and knowledge of drugs and skill in handling drugs and equipment. The ATLS course is normally designed with lectures to teach the core content and the knowledge base, and but more importantly, skills practice, which includes case-based learning and a team approach, and also required to do certain procedures to practice using an animal model. Now, this lecture series offer the first part partially, and the trainer is required also to read and understand, to have background reading, understanding before undertaking this course, and the skills are certainly an important part of it. In summary, therefore, the ATLS course is a system of trauma management that focuses on 1. Management of immediate life-threatening injuries, taking of a concise targeted history, a holistic examination of the trauma patient to identify all injuries and not just the most obvious, and then appropriate and expeditious disposition of the trauma patient. Thank you for your attention.